As we move forward in redesigning renal denervation, not only with the procedure, the technology, the patient population, and how studies were conducted, we now have in fact 3 sham-controlled phase 2 feasibility studies that demonstrate both in the on and off med setting the benefit of renal denervation in improving blood pressure control for these patients with moderate uncontrolled hypertension. At present, we have 3 what are called feasibility or phase 2 clinical trials, 2 with radiofrequency energy delivery, the spiral technology from Medtronic Cardiovascular, and 1 trial with a ReCore technology, which is an ultrasound, an intravascular ultrasound mediated delivery of renal denervation. So interestingly, these 2 therapies working by different mechanisms also demonstrate remarkably consistent results. 2 of the trials, 1 of the ReCore studies and 1 of the Medtronic spiral programs, were performed in what we call an off-med setting. This is when patients with hypertension are intentionally taken off of their medications for a short period of time. We allow the blood pressure to escalate with close clinical observation, and then the patients are randomized in the sham-controlled blinded fashion to either control group or renal denervation. And for an abbreviated period, for example, up through 3 months, we follow these patients and now demonstrate the reduction in blood pressure with renal denervation. That type of trial demonstrates the biologic proof of concept or the proof of principle of renal denervation. But further in the spiral program, and not yet completed for the ReCore program, we've performed a study in an on-meds patient population as well. This is the situation in which we think renal denervation will have more clinical applicability, that is in patients who are already prescribed and taking medications, in which we demonstrate still that the addition of renal denervation further augments the blood pressure lowering effect. To begin with, the reductions that we're observing in the present trials that have been completed is an approximate 10 millimeter reduction in the office systolic blood pressure and generally about a 5 millimeter reduction, or in some instances more, in the diastolic blood pressure. And to keep this in context, this is about the magnitude of blood pressure reduction that we would observe with a single antihypertensive pharmaceutical agent. And moreover, a 10 millimeter reduction in blood pressure, we now know from aggregate of more than 600,000 patients included in hypertension trial, that for a 10 millimeter reduction in the systolic blood pressure, this translates into approximately a 10 to 15% reduction in mortality, a 25 to 30% reduction in outcomes that include stroke and cardiovascular events. So the reduction that we're observing to date in this moderate uncontrolled patient population is definitely clinically meaningful if we assume that same effect from other clinical trials. We might even expect even greater reductions if we evaluate renal denervation in patients with more extreme levels of high blood pressure as well, because to date, one of the few predictors of a reduction in blood pressure is your starting point. The higher the starting point, the greater the fall. That said, we're also embarking in parallel with these clinical trials in a patient preference survey. Here we want to better understand the patient's tolerances for risk-benefit ratios of undergoing a single one-time procedure in comparison to perhaps taking medications for a lifelong commitment that may be escalating in their number and dose of medications, but also perhaps in side effects. And this is important because it falls against the context of non-adherence for patients. We've observed across our clinical trials, as well as many other trials in hypertension, that upwards of 40% of patients may be partially or completely non-adherent to their medications despite best intent and despite prescription of these medications. And what we have in contrast observed with renal denervation is what I might describe as an always-on effect of renal denervation, given that through the entire time period, independent of adherence to medicines, independent of dosing profiles, of dosing regimens of medications, that renal denervation is associated throughout the 24-hour period of a day with a persistent reduction in blood pressure. And this has especially important implications for individuals whose hypertension convey an especially high risk for adverse events, such as patients who have persistent daytime and nighttime hypertension, patients with early morning hypertension as well.